as you enter the room, you can see hopefully on the screen some instructions that we need you to follow in order to get assigned to the breakout room for the topic that you want to participate in today. My name is Alan Fitzer, and you can see that there are two breakout rooms, one on integration of family planning services. If you go to the participant list and click on your name, it would be good if you could then go to more and rename yourself with a number in front of your name, either 1 for integration of family planning services or 2 for digital health. Good morning, good afternoon, good evening. We are here to discuss integrating family planning into other health services. My name is Ann Fitzer with Momentum Country and Global Leadership, and I am just sharing a few opening instructions, and then we'll turn it over to my colleague, Dr. Daisy Ruto, to moderate this discussion. The way this session is set up is that we are trying to replicate what it would be like to be sitting around a round table in Pattaya City, Thailand, having an open and free discussion about integration of services. But we're doing this in a virtual setting. So some of the participants will be able to participate live in the discussion with the moderator and the discussants. We have 3 colleagues who are prepared to give you a little bit of their own experience implementing the integration HIPS. And others among you will be able to participate in the discussion as well. But in order to make the discussion sort of more robust, we've limited to about 20 the people who can sort of speak up in the discussion. And the rest of you are strongly encouraged to share your experiences with integration of family planning in the chat. And I will be monitoring that chat. So I'm pleased to introduce our moderator for this session. This is Dr. Daisy Ruto. She's a co-investigator and leads Jepaigo's post-pregnancy family planning choices study, PPFP choices study in Kenya. The study is a multi-country implementation research study funded by the Gates Foundation that looks explicitly at the factors involved in offering PPFP in different, in both public and private sector contexts. And Daisy leads that effort on the Kenya side as well as being part of the larger investigative team. She also works on other maternal health projects. For Jepaigo in Kenya, has a master's in obstetric and gynecology and has over 16 years of experience in the public health field. And then she will be joined to open the discussion by Dr. Pamela Dongo, a medical doctor and deputy chief of party of USAID RIGHTS North Lango project in Uganda. RIGHTS North Lango stands for Regional Health Integration to Enhance Services. North Lango, a project that aims to increase the effective use of sustainable health services in 9 districts of the Lango sub-region of northern Uganda. Dr. Dongo is highly experienced in the medical fields and also is the director of health services delivery at the project, leading the team that delivers a continuum of integrated client-centered services, as you see on the screen. Daisy and Pamela are joined by Dr. Charles Ondieki Otwori, who serves as a senior technical advisor for Pathfinder International, working on USAID's Afya Pwani project in Kilifi County, Kenya. He has joined that project and worked on that project after many, many years in public service, both in public and private health facilities as a medical officer and consultant obstetrician and gynecologist. Daisy, Pamela, and Charles will be joined by a third discussant, Elaine Rossi, who works for John Snow Incorporated and JSI's Research and Training Institute for many, many years, holding a variety of positions. And she serves as senior advisor for many projects that JSI implements. Two of those are in Timor-Leste, or yes, and one of them is called Reinforced Basic Health Services Project. And another was a health improvement project that occurred prior and over the last 10 years. Ms. Rossi's specialization in family planning and reproductive health includes the integration HIPS and that we are discussing here today. You will also hear today from our subcommittee co-chair. The program implementation subcommittee for ICFP is one of the newest subcommittee, and Ellen has elected to join our discussion on program implementation. She is the director of USAID's Office of Population and Reproductive Health. She provides high-level leadership to the agency's family planning and reproductive health agenda and portfolio. You can see that she oversees and manages a large budget for USAID overall and for the office in Washington in particular. She has 30 years of experience designing, managing, monitoring, evaluating international family planning and reproductive health programs, and is continuing a long career in the office that has spanned many good years. She has a master's in development economics from the Fletcher School of Law and Diplomacy, and spent 11 years of her childhood in Hong Kong and Thailand. So with that, I'm going to turn it over to Dr. Ruto and welcome you to join in our discussion, either by unmuting yourself after the discussants say a few words, or by contributing to a vibrant chat discussion. Thank you.
Thank you very much, Anne, for that kind introduction. Good morning, good afternoon, good evening to all of you. Welcome to this session. This roundtable will be focusing on integration on FP, the family planning high impact practices into other health services. And just to note that these high impact practices were identified by a technical advisory group of international experts, and I will briefly introduce the three high impact practices that we'll be discussing today in our roundtable. And this includes immediate postpartum family planning, post-abortion family planning, and family planning and immunization integration. Each of these high-impact practices summarizes the evidence, provides implementation tips for proactively offering family planning, and Anne will be actively sharing this link of the specific high-impact practices in the chat box. So for the immediate postpartum family planning high impact practice, so this is the practice that tells us that we need to offer contraceptive counseling and services as part of facility-based childbirth care prior to discharge from the health facility. And this is very important because providing family planning counseling as part of childbirth care really raises that awareness of the importance of birth spacing and postpartum contraceptive options to those women who who deliver. It also increases the number of women and partners who can be reached as they come to through the facility-based childbirth services. It's also important because women have more family planning options during that immediate postpartum period, as we know based on the 2015 WHO recommendations after the revision of the medical eligibility criteria. And it's also important because offering modern family planning as part of childbirth services increases postpartum family use. For the immediate postpartum family planning high impact practice, we do have a theory of change that really outlines those barriers that affect uptake of the immediate postpartum family planning, including issues around, health staff bias, issues around knowledge, availability of those methods within the facility, client awareness, and even HMIs that do not support documentation of this PPFP, as well as those social, cultural, and gender norms that affect the attitude of these women in terms of taking up the immediate post-pregnancy family planning. So the high impact practice is to offer contraceptive counseling and services as part of facility-based childbirth care services, of course, prior to discharge from the health facility. So it also outlines the service delivery changes that need to be made in order for this to be immediate PPFP to improve. And this includes changes at the national level, as well as, the subnational levels and the facilities. And it includes issues around updates on the guidelines, train capacity building of service providers, availability of the contraceptives, issues around privacy, and even linkages to other community programs. This theory of change also outlines the benefits that these women will receive as a result of taking up the immediate postpartum family planning, including improved understanding of fertility and contraceptive options during that postpartum period, as well as increased social support for use for postpartum FP use. It also shares outcomes, and of course, these outcomes include increased use of postpartum family planning, reduction in closely spaced pregnancies, of course, which improves that outcome for both the mother and the baby, as well as reduction in unintended pregnancies. Next, Anne. So for the post-abortion family planning high impact intervention, we need to proactively offer voluntary contraceptive counseling and services at the time and location where women receive facility-based post-abortion care. And this is very important because post-abortion family planning can reach many women and girls in need of family planning counseling. And it also helps clients to achieve reproductive intentions and is likely to provide cost savings for women, families, and the health system. Unsafe abortion is a major contributor to maternal morbidity and mortality in very many of our setups. And family planning after post-abortion care can reduce the subsequent abortions. Women are also at risk of pregnancy almost immediately after abortion, and the post-abortion family planning can reduce that unplanned subsequent pregnancy. So the theory of change behind this particular high impact practice, in terms of the problem statement, women are at risk of unintended pregnancy almost immediately after abortion. So that's really a big challenge, and the high impact practice is really to proactively offer that voluntary counseling, contraceptive counseling, and services at the same time, same location, if possible, the same room where the women receive this post-abortion care. The outcome we expect is that post-abortion care clients leave the facility with an effective method, which is also of their choice. And in terms of impact, we'll see fewer unintended pregnancies and fewer women at risk of unsafe abortion. So for the family planning and immunization high impact practice, we need to offer family planning information and services proactively to women in that extended postpartum period during routine child immunization contacts. So this means that not in campaign setups, but in contacts and outreaches. And this is really important because we do know that immunization really has a very broad reach. In fact, is the cornerstone to a lot of the primary health care. And most women will be able to bring their children if not for all the immunization contacts for this child. Child immunization services involves multiple timely contacts with the mother and the baby within that first year, and those are all opportunities to be able to provide family planning. Again, evidence suggests that integrating an integrated model is acceptable to both clients and providers. So for implementation evidence that has been gathered, the clients are happy, the mothers are happy about integrating this service, and the providers are also happy to offer this service. And increasing access to postpartum family planning contributes to overall achievement on child health goals as well. So in terms of the delivery models that this high impact practice offers, there are several. And just to note that one of the models is to have a combined service, provision to offer the services within the same day at the same location, or offer a single service provision, including referral. So immunization or planning provided along with the education, screening, or referrals for others. So with that brief introduction on the three high impact practices that we'll discuss today, I want to take it over to the three discussants. This is Dr. Pamela Dongo, Dr. Charles Ondieki, and Elaine Rossi. Thank you very much for accepting to be our discussant, lead the team in this discussion. And I want to give you about 3 minutes each, and to give a response on the high impact intervention which you have implemented within your programs. So maybe going back to Pamela Dongo, kindly tell us very briefly about the project context where you worked to implement either one or more integration the high impact practices which I mentioned earlier, and which particular high impact practice will you be discussing about, and how you decided on devoting your time and resources to that particular high impact practice. Dr. Pamela?
Thank you, Daisy. Good morning, good afternoon, and good evening. I'm glad to share the work in the part of Northern Uganda that's led by JSI, implemented by JSI in the 9 districts of this region. And I will highlight the work that we have done around integrating family planning in the immunization services. Last year, the beginning of last year, we did look at the data from our region, and we noticed a gap in accessing family planning services by women who had delivered. The immunization coverage was quite high in the region, and over 90% for DPT1, which is given at 6 weeks. However, we noted that only 30% of the women who brought their children for that vaccine actually accessed postnatal care services, of which family planning is a critical part. We did a small assessment in about 30 health facilities out of the 245, and we found cross-cutting gaps within the region. Our project therefore decided to institute a quality improvement collaborative using quality improvement approaches, speak to the healthcare workers, speak to the district managers to try and identify what were some of the bottlenecks to accessing family planning services or improving postnatal care services for the women who brought their children for immunization. And some of the key gaps that we identified were issues around how the immunization was being done, both in the facility and in the communities. In the facilities, it was being done at a specific place. The people who provided the immunization really focused just on the jab for the children, and there was no counseling or service provision for family planning services given to the mothers then. So there were missed opportunities for providing family planning services within the immunization clinics. Even when the outreaches were done, the outreaches focused only on immunization services. There was also a gap in healthcare worker knowledge and capacity, because the teams who do the immunization in this country are mainly a group that we call vaccinators, who are really lay healthcare workers who are only trained on immunization. And there was a missed opportunity to skill them and build their capacity to provide additional information to the mothers or to their partners about family planning services. Issues around healthcare worker gaps as well. So there was no supervision of the vaccinators, their lay healthcare workers, and family planning wasn't prioritized at the immunization services. There was a clear lack of knowledge about immunization, about the ability or the opportunity to integrate family planning within the immunization services as well. Issues around supplies, especially when they went out to the communities, they were only carrying the vaccines and not carrying any information materials or any family planning supplies as well. So leveraging on some of the opportunities that we identified, we worked with the district leaders, the health leaders in the district, looked at the communities that had a high population but a high unmet need, and really worked to address some of these gaps. We focused on building the capacity of these lay healthcare workers, the vaccinators, to be able to provide counseling messages and provide some key family planning practices that they were able to provide within the community or even within the facility. And then they would refer, especially for the long-acting family planning methods that they couldn't provide within the community setting. We also identified that many of the women in the region, about 85% of them delivered in lower level health facilities, which only provided delivery services, but the midwives there were not skilled to provide family planning services. So we worked with the higher level health facilities to train and mentor the midwives at the lower health facilities to provide postpartum family planning services. There was also an issue around supplies, because the way the supplies come in here is that they go only to the major health facilities or the high volume health facilities. We worked with the districts to ensure that even if the supplies go to the higher level health facilities, they were able to quantify and redistribute to lower level health facilities, especially where we had trained the healthcare workers to be able to provide the facility. So what we have seen in a period of almost 6 to 8 months is that we have been able to improve the percentage of women who bring their children for immunization who access family planning services from 30% at the beginning around February last year to around 60% by the end of July. And we have taken the learning that we had from the 30 health facilities in which we started this intervention, what I call the collaborative health facilities, the quality improvement collaborative health facilities, and we are scaling up learning to the rest of the facilities. And we hope that by the end of this year, which is around September, we'll have scaled up to around 150 health facilities. But it's really around identifying what the gap is, identifying the missed opportunities. One other thing we saw was that just realigning the client flow in the health facilities. was able to improve family planning uptake, because the mothers come to the health facility and they line up in a long line for the vaccine, but just working with the healthcare workers to realign the client flow and ensure that a triage issues around family planning messaging is addressed. Some of the methods are provided. You address the issues around myths and misconceptions, and then you're able to take that out as well. In the communities, we have also tried to train more lay healthcare workers in terms of, for example, we have a program here, the DREAMS program, which targets, which is a global initiative that targets adolescent girls and young women, 9 to 24 years. And we have been able to train some of the peers in the community, taking it away from the healthcare workers, but they're trained and they're able to provide key family planning messages. We've also trained the village health teams, who are lay healthcare workers in the community, to be able to provide messages and also to be able to provide some of the services. And we have seen a significant improvement in the proportion of women who are able to uptake postpartum family planning methods, even those as early as 48 hours after delivery. So we have had to deal with both facility interventions and also introduce some community interventions to address some of these gaps as well. Thank you very much.
Thank you very much, Dr. Pamela, for sharing those very useful insights. Certainly quite impressive results. And while you focused on that family planning and integration with the immunization, very impressive increase from 30% to about 60% in a period of less than 1 year. But I want to take it back to the other discussants. And next, I will call upon Dr. Charles Otori to just give us an insight from his program, citing anything that really was aligns to what Pamela has already mentioned, or anything else that you really want to focus on in terms of the other high impact practices. Over to you, Charles.
Yeah, thanks, Daisy, for the opportunity to share our learnings from the Afya Pwani project. This is a USAID-funded project implemented by Pathfinder in Kilifi, that is in Kenya, East Africa. And we've implemented the project now. We are in the 4th year, close up phase of the project. And Kilifi is an area with had that during the Kenya Demographic Health Survey of 2014, a modern contraceptive prevalence rate of 34% against the national of 53, and also with a very high unmet need. And one of our main objectives was to increase access and utilization of quality family planning so that we address the unmet need. And we've done that through a multifaceted approach, both at the community and also at the facility level. We've implemented especially family planning in over 140 facilities, and we've also worked with over 1,000 community-based distributors, also addressing, also with having about 300
I think we are losing Dr. Charles.
Hello.
Hello, Charles, go ahead.
Yes. So part of the challenges or the gaps which we're addressing are similar to what has been shared earlier. That is the the issue of cultural and beliefs and issues of ideas and also missed opportunities because of commodity stock out. Hello, sorry for that. Hello.
Hello, go ahead, Dr. Charles. We can hear you now.
Yeah, so I'll go forward and share some of the learnings we've had. And one of the assumptions we make is about postpartum family planning, that most healthcare workers will know about it, but we find that at times they are not, and also there's a bit of provider bias towards the methods. And so for you to successfully implement, you have to also be cognizant of the continuity of care, both in place and the life cycle, so that starting from preconception to postpartum, and also involving the community structures, so that they're also aware, especially the community-based distributors, they're also aware of what postpartum family planning is. And also going further is using a systems approach before initiating postpartum family planning, mapping out the facilities capabilities, checking the staff preparedness and skills, and also availability of equipment and commodities. And also one of the other issues was documentation. Initially, early in the program, the national documents reporting tools were not aligned. But once they were aligned, then it became easier to collect that data and also motivate the healthcare providers to report on it. The other issue is also having job aids and protocols in place. And in terms of capacity building, we did several trainings, but one of the things which we learned is that about post-training follow-up, and also ensure that, and having a structured mentorship program in place. It actually ensured that the healthcare providers picked up the skills and were more competent, and also investing in models for practical demonstrations. And also in terms of the facilities we implemented, on-site sensitization was also quite key in ensuring that there are no barriers within the facilities. In terms of documentations, one of the gaps we noted is that at times patients are cancelled during antenatal, but as they come into the delivery, there's no record of that. So noting that the progress of the counseling session, whether a patient is already thinking about or has declined, so that really helped in ensuring that the counseling was successful. The other area which we really had a great improvement and which is a practice which advocate for is group antenatal care. And in mothers who we had group antenatal care and also in postnatal care, we had the mama and the binti groups where we followed up women longitudinally until the baby was fully immunized. We found it as a very good way of integrating the whole spectrum of reproductive, maternal, newborn, child health, adolescent health, and family planning. And this was mainly because of the structured nature in that kind of follow-up, and also in terms of what you find in the other, when there's no group care, is that when a mother comes, they don't have that relationship with their provider, and also the continuity of care. But in group care, the continuity is good, and we had higher utilization of family planning. And also during the group care, it provided an opportunity for focused group discussions so that we're able to address any myths and misconceptions on postpartum family planning. And this helped us in designing targeted behavior change messages for postpartum family planning. In addition, also, strengthening the capacity of community-based distributors and also the male champions and working with other key community resource persons was also quite key. Thank you.
Thank you very much, Dr. Charles, for those very good experiences which you've shared from your program. And I'd like to note that there are similarities in terms of the gaps which the earlier discussant did note, including issues around myths and misconception, challenges with the commodities, as well as equipment, but also noting that what was common for both of you was that you focused also on having a community program, and in the case of the first discussant, using the lay healthcare providers in the community to really further these PPFP services, while for Charles, mentioning that you have over 1,000 community-based distributors for that family planning, I think is quite similar in terms of programming. I also want to bring the aspect that Charles has introduced on the issues around the healthcare providers not always having the correct knowledge and the strides they've made to make sure they improve that capacity for the healthcare providers to be able to provide those services, including the mentorship, whole site. But also something quite interesting is the use of a new approach, which is the group antenatal care. I'll stop there and invite my third discussant to share her experience, and this is Elaine Rossi. Elaine, welcome. Please take it away.
Thank you very much, Daisy, for that introduction and for your comprehensive and very interesting overview of the HIPs that we're talking about today. And thank you also to Dr. Charles and Dr. Pamela for their presentations from other countries. Today, I'll be talking a little bit about Timor-Leste and the work that has been done in Timor-Leste in the past 20 years, or slightly less than 20 years, since it became an independent country, which was in 2002. This is extremely relevant because after a period of several decades of civil war, the population in Timor-Leste was provided the opportunity to vote on independence, and they did so in 1999. The Indonesian government that had occupied the island that is now the home to the country of East Timor or Timor-Leste, when they withdrew, they decided to destroy much of the health infrastructure, health, education, and other infrastructure as well. So what that means is that in 2002 to about 2008, a fledgling government and a fledgling Ministry of Health had almost no infrastructure. They were starting with a country population that was traumatized, and their public health statistics were disastrous, as you can imagine. The maternal mortality rate was the highest in their region. It was estimated to be over 900 per 100,000 live births during that period. As you would assume, the neonatal infant and child mortality rates were extremely high. There wasn't any contraceptive prevalence rate worth measuring. A major donor was present on the scene, and that was USAID, along with UN agencies and some humanitarian and relief groups. And one of the reasons I bring up the importance of USAID's funding and other US government investments in Timor-Leste during that very early period is it laid the groundwork for much of what happened in the past 8 to 10 years that allowed the implementation of the HIPs for family planning in Timor-Leste. So leading up to this period, USAID invested in what the Ministry of Health thought was their priority, and it was at the time, which was EPI. So a strong and effective EPI system was developed, primarily funded into the Ministry of Health by USAID with a few other partners. And because of that, over time, there was the ability to integrate other services into what was the backbone of a system that met some of the communicated needs of the Ministry of Health and the population at the time. So moving forward a few years, USAID funded the Health Improvement Project and then a project known as the Reinforced Basic Services Project that is just wrapping up now. And the Reinforced Basic Services Project, the most recent one, worked at both the national and the district level in Timor-Leste to increase access to modern contraceptive methods, to safe delivery at a variety of facilities, to EPI, and to selected child health services. And the way the implementation of the high impact practices for family planning had an impact, most specifically, was that there was the ability to work on both integration for EPI and integration of family planning into postpartum family planning, sometimes in parallel and sometimes consecutively as government policies, standards, and protocols developed over the course of those years. So having a donor that worked on policy and practice at the same time is a major lesson learned from the work in this extremely fragile environment. Some of the most exciting, we think, outputs are that immunization rates, even throughout the COVID-19 pandemic, have remained substantially the same in the majority of the districts that USAID and other partners have continued to support the government. And at the national level, high quality competency-based training and the trainers that were supported under this project have continued to support their trainers at the district level. So there hasn't been this extreme drop-off in access or use of services that you've seen in many other countries. One of the other aspects of the HIPs that are really important is increasing access to a wide variety of family planning methods. And that was a very large challenge in a country where the population, generally speaking, didn't trust authority. They didn't trust the quality of services at specific facilities. And so it was a long process. And some of the things that happened just in the last 2 years was an increase in facility-based deliveries from 32 to 40% at the hospital level and 8 to 22% at the clinic level, which meant that women coming for deliveries could also get family planning at a service delivery site. Before that, so 4 years ago, they could only receive services at community outreach, where family planning, some antenatal care, immunization, and a few other services were provided typically one day every other month as part of an outreach strategy. So this was a huge shift in terms of where focus was provided and how family planning became available to women and men throughout Timor-Leste, and specifically in the districts where USAID funded activities. Just one more statistic to give you an idea of the change over the course of the last 4 years in the most intensively supported district in Timor-Leste is that the percentage of women using long-acting contraceptive methods went from 5% to 32% in about a 4-year period. And that is due to a number of interventions working at the same time, but also the ability to implement high-impact practices, as I said before, sequentially or in parallel when the government was ready. And so I'd welcome your questions and comments and look forward to hearing more from all of you.
Thank you so much, Helen, for really giving us that background of Timor-Leste and that background of how the infrastructure has evolved over a period of time, citing that those challenges and the fragile environment that did exist, and also how that has improved over the last 4 years, because the USAID program, they are focused on the high impact practices. Thank you very much. I see that there are so many questions in the chat box, and I just want to open it up. If Anne, you could help highlight one or two of the participants. If you could unmute them and they can ask a question. Anne?
Yes, Daisy, I think people who ask perhaps questions about overcoming either cultural norms or resistance from providers, if one of you wants to just unmute yourself and ask that question, or if there's just other members of the group who want to share how their experience is similar or different from what has been said, please go ahead.
Yes, I see Bushra, your hand is up. Please go ahead.
Hello, everyone. Thank you so much for the great presentation. It was informative, and from our experience in Yemen, I think that I can get a lot from what you said today. I had 2 concerns, which I needed to know more about to implement it in Yemen. We are implementing a USAID project in 220 health facility in Yemen. And one of our issues we faced when we started to advocate for integrating family planning with other departments, that the resistance was from the immunization, from the API department themselves in the ministry and in the lower level, because they thought that it may affect immunization, because if the man think that he doesn't want his wife to hear about family planning and he's extremely hating this idea, he ended up taking the child and prevent him from taking the immunization, and that affected the immunization and dropped it down. This is one. And the second one was the communities where we should put it, because we have many issues with the cold chain, with the supply system, and if we worked with integration, where we will put commodities. We agree in Yemen to put it in the family planning and only refer the moment to the family planning department. But if there's an outreach and work, this is also a question that it may have some obstacles in humanitarian setting places. Thank you.
Thank you very much, Bushra, for sharing that unique context from Yemen. Certainly many from that region can relate to the issue of in terms of male involvement. I will still request anybody else who would want to ask a question or share a comment. And anyone you see in the chat?
Sorry, I don't know how to raise my hand, but I'm Rose Sakala from Malawi.
Rose, go ahead.
Yes, I've heard the great presentations which our panelists have shared with us. but I've not clearly seen how the young people and the young women are being targeted and their role in access to whether post-abortion care or family planning services, and then also the engagement of the adolescent boys and young men. I'm saying this because in Malawi, the adolescent boys and young men play a very critical role in terms of uptake of FP services for the adolescent girls and young women. And the issue of abortion is still not legally accepted, but maybe if there are any complications, then the young women can access it at the nearest health facility. But we still have a lot of technical issues and maybe capacity in most of the health centers, and they make referrals to the central hospitals or district hospitals which are a bit far from the location. So I just wanted to know, especially from those in the Africa region, maybe we might have some similarities and maybe they may want to share their experiences. Thank you so much. Like I said, my name is Rose Sakala. I'm working with Johns Hopkins under USAID funded program on child marriage. Thank you.
Thank you so much, Rose, from Malawi. And I really would want to hand over to the session chair for some final remarks, but maybe to respond to this last speaker, it's just to give an experience from the program in Kenya, where I implement postpartum family planning, to say that for the adolescents, we were really able to prepare the facilities and the service providers to offer youth-friendly services to these adolescents, and then also implemented a community component where we did have young mothers clubs that were supported by a community health volunteer, and of course linked to a nurse in the nearby facility to be able to give that content around family planning. So at this point, I would like to so just before I hand it over to the session chair, I will ask Pamela just to, Pamela, in a minute or two, just comment about integration with immunization in a conflict situation area. Dr. Pamela?
Thank you, Daisy. The challenge in a region like where our project works is the dysfunctional health systems. Challenges with supplies for health services, including family planning services, supplies, healthcare worker gaps, both in terms of numbers and in capacity. So in a region like mine, where the effect of the war in northern Uganda has been, it's getting better now, but still, you know, looking through the health systems, you see the challenges of a region that has had a war for a long time. So the focus is really on building the systems, the human resources for health, district leadership and governance, and working very closely with the Ministry of Health to try and ensure that the things are in place for the people to get the services. But also you're dealing with a community that is not very open to accessing health services from the health facility. The health facilities are far and people do not go to them. So it's important to not just look at the health facilities when you're looking at some of the services like family planning, but to identify communities, high population communities or high burden communities, but those that have a poor service uptake. We work in a region that has landing sites by the lakes. The roads are very bad, the health facilities are very far. So to recognize those areas and move out of the health facilities and take the services, in this case, family planning services, to the community. But because the healthcare workers are very few, the capacity is very low, we had to identify other resources within the community whose capacity we can build to be able to provide some of these services, but maintain the supervision and accountability by the district leadership and by the health facilities. So we were able to identify key community resource persons who are even just able to provide a message, just able to go household to household and speak to families, speak to the women and their partners within the community, and be able to provide some of the family planning services, or be able to provide them the link between the facility, between the community and to the facility, and follow them up. Another key intervention is working very closely with community-based organizations, the civil society organizations. Coming from a region, there are very many small but very incapacitated community-based organizations that reach the communities, but maybe don't have the funding or don't have the capacity to provide the services that they should provide. So our project works with the civil society organizations or community-based organizations, skills them, provides them the tools, but also we have a sub-granting mechanism where we provide some funding to these organizations, and they are able to reach the communities and reach the facilities as well. But I would just like to highlight the role of lay persons, for example, especially when we are talking about adolescent girls. At the beginning of our project, we had focus group discussions interfaced with adolescent girls, and they told us that they really would like to access family planning services, but they would not like to access them at the health facilities. One, because the health facilities are far. There's a lot of healthcare worker bias about providing family planning services for young girls. So they really opted for family planning access within their communities, but also that it is given to them by their peers. So working with them, they identified peers who we trained, and they were able to take services out to reach the girls. And when they do that, they're able to reach the partners as well. We don't have a big component of reaching the boys, but we hope that we will, as we continue our work, we'll be able to reach the men and the boys as well. Thank you very much.
Thank you very much, Dr. Pamela, for sharing those experiences about how you went about the issue on adolescents. I would really like to leave it there and hand it over to the chair, just to say that I want to thank the discussants and the participants for all those compelling examples and the questions. I know that we had so much to discuss, but not enough time. And thank you very much. And handing over to Ellen. Ellen?
Yes. Thank you, Daisy. Hope everybody can see me now. Thank you for your terrific facilitation, and thank you to all the speakers who shared their examples, and to everyone who had a really good and interesting chat going in the chat box. This session was organized by the Implementation Subcommittee, which I'm part of. It's a new subcommittee for ICFP that aims to provide opportunities and space in the conference for practitioners like yourselves, implementers, service providers, governments, youth-led organizations in the private sector from across regions and sectors to exchange experiences on what works and what doesn't, and to adapt the do's and don'ts for their own contexts. We saw this roundtable as one of those opportunities, focusing on how high impact practices have been implemented in countries. We know that many of you joining this virtual discussion might not typically get the chance to travel to an international conference, and we especially wanted to hear from you about what's working and challenges you're facing and how you could overcome these. So as I noted at the start, it was great to see the conversations that were happening in the chat. We'll look for a way to capture those and possibly post them to our community site so that those conversations can continue. We are keen to take this conversation forward as we move towards the in-person International Conference on Family Planning in Thailand. So if you'd like to stay connected with us and with each other following this conversation today, we urge you to visit the implementation community page on icfp2021.org. And in the next week, you will find there a place to give feedback on how you found today's roundtable, and a sign up sheet where you can opt in to be kept updated on program implementation. We'll also be uploading the illustration that our recording artist has developed to capture today's discussion. And our artist is Jerry Metzger. I don't know, Jerry, if you want to put your screen on so people can see a little bit about what you've been doing. As I say, we will be merging the illustrations from the English and the French sessions on these topics, and those will be posted onto the website. And finally, if you are interested in learning more about the high impact practices, you can visit the high impact practice website, www.fphighimpactpractices.org. You can help strengthen the HIP briefs to support evidence-based programming by engaging in a number of ways, which you'll find under the Engage tab on the HIP website. You can contribute your expertise in a technical expert group, provide feedback on the briefs, submit new brief concepts, and sign up for the quarterly newsletter. If your organization is not already a HIP partner, you can find out more about joining the HIP partnership by reaching out via the contact form on the website. So I want to thank you all again for choosing to participate in this discussion and for helping keep the conversation going. We are looking forward to keeping the conversation going forward on our road to universal health coverage with family planning. So thanks again to everyone and to all the organizers who put this session together. Thank you, Daisy.
Thank you. Bye.
Stars with the power to be seen across the world. We're not the future, we're the present. Invest in us and you will see the world is changing.
Because our body